Disclaimer. Opinions expressed are those of the content creators and do not represent any employer or entity. The information shared is for informational purposes only and should not be construed as medical advice or used in any legal capacity, including establishing standards of care. All efforts have been made to comply with HIPAA regulations. No guarantees are made regarding the accuracy of statements or opinions provided. Interaction with the podcast does not establish a doctor-patient relationship. Please enjoy this podcast responsibly.
All right, welcome back to another episode of Pod Patrol with your host, Dr. Jeff Dikis.
And Dr. Leland Jaffe.
How you doing, Leland?
I'm good, you?
Pretty good. I cut down a tree today. I put my surgical skills to the test, and I busted out the chainsaw and took down a tree.
Does Ashley make sure your life insurance policy is in place before that?
Yeah, she wanted no part of this. She was not even outside. I came away with one small scrape. Other than that, came away unscathed. So all of my appendages intact.
Chainsaw is one of those tools you just feel, I don't know, powerful using.
Mm-hmm.
Yeah.
If I can use a bone saw
experience.
Yeah. If I can use a bone saw, I can figure out how to use a chainsaw and not, do too much damage, hopefully. So
I agree.
Anyways,
I was cleaning a child's bedroom today, so a little more finesse, but productive nonetheless.
Also, no injuries?
No injuries.
Okay, good.
A few injuries to the floorboard with some staining, but not too bad.
Yeah. I guess ladder. Ladder could be... I was kind of making a joke about how do you get hurt painting, but there's lots of people that get hurt painting. Usually ladders involved in that.
Yeah. No injuries.
Good.
Yep.
So
let's jump into it.
Today we're going to talk about pediatric ankle fractures. So obviously we see pediatric ankle fractures and, sometimes they're not too different than adult ankle fractures, and sometimes they end up being quite a bit different. So, when I see someone who's peds and they come in for an ankle fracture, there's a few things that I'm very kind of aware of from the beginning that delineates a difference between an adult and a pediatric patient. But a lot of the same protocol are intact, identify the fracture, imaging, all those things we'll kind of go through. But just specifically, these are kind of taking us back to school a little bit, but good to rehash a little bit. So the physis at the distal tibia is what we're talking about mostly. You can have distal fibula physeal injuries as well, but the tibia is obviously the more of the significant of the two.
Mm-hmm.
So the physis is that cartilage disc at the end of the long bones where the bone grows from. And the chondrocytes, those cartilage cells, they die and the cartilage matrix calcifies. The osteoclasts come along and eventually the osteoblasts replace it with bone. And that's how we get kind of the elongation of bone. Just a little kind of rehash there from back in school. So why don't you take us through the Salter-Harris classification?
Yeah, absolutely. I mean, this is certainly one students should be well aware of. Salter-Harris is going to show up on every board exam as well, too. So always good to review and kind of understand what we're talking about. Yeah, I think the challenging ones are sometimes the Salter-Harris 1 injuries, which is just a physeal injury. Sometimes identifying that on a radiograph can be a little bit challenging, especially when you have a physis that looks irregular or sawtooth and you're not really sure, is it injured, is it not? And we can talk through that as well in terms of the physical examination. Salter-Harris 2 is you have an injury. Do you want to talk about Salter-Harris 1 real quickly?
No, I was just going to agree with you because when you look at a lot of growth plates, when you see enough pediatrics, you look at enough physes, whether it be in the calcaneus or tibia or wherever, and there's a lot of variability there. It's very difficult sometimes to identify whether there's an injury through the physis or whether that's just their normal anatomy. In a perfect world, they would have a foot x-ray or an ankle x-ray from a year ago and you can compare, but that's pretty rare in peds. They usually don't have a reason to have an existing or a pre-existing x-ray to be able to compare to. So I agree with you. That one can be very tricky.
Yeah. So yeah, when we talk about Saltair's 2, we're talking about an injury through the physis and then into the metaphysis. So that's the buzzword of the Thurston-Holland sign. Should be fairly easy to pick up on the radiograph, certainly on a CT scan. Do you get a CT with just about all your PEDS fractures?
I do. We'll jump into that and
Yeah.
why we do that. But yeah, CT scan is almost a necessity.
Yeah. Yeah. Number 3. So Saltair's number 3 of an injury through the epiphysis into the physis and out the end of the physis. So that's your number 3 injury. Number 4 is through the metaphysis, through the growth plate, and into the epiphysis. Having a hard time with that word today. And then the 5th one is just compression of the physis. So that's where you can have premature closure of the growth plate. I mean, I suppose you can with some of the other injuries as well too, but this is one where you're a little bit more concerned about part of the physis closing down early.
Yeah, we're going to jump into that here in a little bit with some of the research articles, but premature physeal closure is something to know about, be aware of. And that's one of the biggest reasons, or I should say one of the biggest differences between adults and peds is that we have to have such appreciation or understanding of the physis and how it needs to be oriented to continue with that normal growth so that they don't have premature physeal closure, which could cause a significant deformity in the future.
Mm-hmm.
So when these kids come in, there's a few things that I'm paying attention to on physical assessment. What is the age? That's going to be a giveaway for how early they are in the bone maturation process and the physeal closure process. Is it a girl or a boy? We know that the physeal closure times vary between boys and girls. Imaging. Are we going to stick with x-rays or are we going to bump it up to next level and get a CT scan? We'll talk about that. And then the extent of the displacement. So when it comes to the physeal closure, we know females are a little sooner than males. Females 12 to 17, males 15 to 20. And we know the distinct pattern of the physeal closure. I like to think of it as the reverse of log Hansen. So if you think about a log Hansen PER, it starts medially and then goes anterior and then lateral. And then posterior, the physeal closure is the reverse. It starts medial, goes posterior, lateral, and then finally the anterior and anterolateral. So one thing to kind of keep in mind is that a certain group of patients, usually 13 to 14 years old, are around the time where they have physeal closure, but not the anterolateral portion of their physis, just by the nature of when each portion closes. And those are the ones that are prone to that Talot fracture, that anterolateral distal tibial physeal fracture, that Talot fracture. So something to be aware of that makes sense when you know where the physis is closing and at what ages. So be aware of that Talot fracture for, 12, 13, 14-year-olds of that anterolateral distal tibia. So to me, the most complicated thing that you could possibly see when you have a pediatric ankle fracture is the triplane fracture. Does this scare you as much as it scares me?
There's a lot going on. And I think there's a lot of different patterns you have to appreciate in terms of reduction and, like you said, aligning up the physis. So yeah, these can present some unique challenges.
So a triplane fracture is what it sounds like for those who don't know. We have fracture patterns that are in all three planes. You can see here on the CT scan, you got a lot going on. You have multiple fractures, both above and below the physis, through the physis, and obviously there on the CT scan, it's involving all three planes. So we're going to call that a triplane fracture.
Yeah.
So one thing that may be a little bit different about this would be to attack this with a 2-incisional approach. Kind of similar to how we tackle talus fractures. I always do my talus fractures with a 2-incisional approach. But when you plan ahead, it's not a bad idea to have some medial incision and some lateral incision because you want to tackle each of these fractures kind of independently. And it's really hard to get all the way anterolateral from a medial incision and vice versa. So planning ahead with a 2-incision approach is usually a good way to tackle these triplane fractures.
Yeah. And one other thing to think about with the triplane is, again, that it looks like a Salter-Harris 3 on your AP view and a Salter-Harris 2 on your lateral view. So really just make sure you appreciate all the different projections so you can, really determine, are you dealing with a fairly simple fracture pattern or one that's a little bit more complex like this?
And I think that's a tricky thing. We'll jump into that here in a little bit, but trying to figure out, do I need to get a CT scan? And we'll find out later that the answer is yes.
Mm.
So this is an interesting study out of the Journal of Pediatric Orthopedics from 2021. And it's a systematic review meta-analysis of all physeal fractures distal tibia. So they pulled together a ton of different studies, ton of different information, and it kind of summarized it for us. So the most interesting takeaways from this study was that they found a total rate of premature physeal closure of 13%, and Salter-Harris type 4 fractures the most likely to develop that PPC. Second in line would be Salter-Harris type 2. They found that open reduction was associated with a lower risk of PPC. So those who went in and reduced the fracture and fixated it had a lower risk of premature physeal closure. And out of all the data that they found and came together at the end, they found that residual displacement after reduction is the most significant factor in predicting PPC. So if they underwent reduction, whether it's closed reduction or ORIF, if there was any residual displacement, that was the most significant risk factor for developing PPC. What does that mean? Well, what that means is if you do closed reduction of, I don't care what you're talking about, Salter-Harris type 2, and you have residual displacement, that patient is at high risk for premature physeal closure. And if one area of the physis is damaged and closes sooner, the other area of the physis continues to grow and they will develop a deformity, either a varus or a valgus of the distal tibia. So, if you do a closed reduction and they have residual displacement, that's a patient that probably needs to go to surgery, clean out the periosteum that's most likely preventing your reduction, and get optimal alignment for that patient, because it can present with such significant deformity down the road if we're not adequately and optimally fixating them.
Yeah. So I think with, again, dealing with pediatrics is obviously a lot different than adults. In adults, we look at the ankle as I always know it as a clock, or, you kind of look at it as a circular pattern. And if you have multiple breaks within those four quadrants, if you will, it's an unstable fracture or a bimal equivalent type fracture that needs to be opened and reduced. In terms of the pediatric fractures and some of these different patterns, what's your threshold if you're attempting a closed reduction of, let's say, a Salter-Harris 2 or something? How much displacement can you tolerate before you open it up?
See, the research varies on that. So the research says that they could tolerate up to 3 millimeters of displacement. I don't feel comfortable with leaving 3 millimeters of displacement. That's just me. I think about how I would want to be treated or how I would treat my own child. That feels like a pretty significant amount of displacement to tolerate. So I'm looking at like 1 millimeter of displacement when I'm, if it's anything above that, then I'm going to go ahead and err on the side of caution, because once the bone has started to heal and they develop premature physeal closure, there's no treatment there. I mean, you can do osteotomies later, you can do corrective surgery, but there's no way to undo that.
Right.
So I have a pretty low threshold for getting them into the OR and just reducing it and making it as good as it can be. And that's not just peds. That's any ankle fracture. Again, it's how I would want to be treated, and it's how I would treat any of my relatives. You see a fracture, like, oh, okay, that should heal. Well, yeah, it'll heal, but that doesn't mean it's optimal. So I have a pretty low threshold for just taking people in, putting them in back to optimal alignment and fixating it. In kids that gets a little complicated, because then you're signing them up for 2 surgeries most of the time, where you're going to go in and take the hardware back out. But I think the risk of physeal injury and premature closure is so significant that it's worth it to go in and do those surgeries. What do you think?
No, I agree. I think the threshold to open, reduce, and fixate is certainly lower.
Yeah. So speaking of CT scans, so I order a CT scan on every single pediatric ankle fracture. I don't even care if it's just very subtle, a little distal fibula, Salter-Harris, 1, 2, don't care. I'm going to get a CT scan for the most part, because and the research backs it up, it's very common to miss injuries on X-ray compared to CT. So this is a study out of the Archives of Orthopedic Trauma Surgery 2010, looking at growth plate fractures of the distal tibia, CT imaging necessary. So what they found was, I'm going to summarize it here. You don't even have to read the article. I'm going to summarize it for you. Yes. I just saved you like 20 minutes of reading this article. That's all they needed to put was yes. Yeah. So basically why we need a CT scan. Well, what they saw was that CT ended up revealing significantly more fragments than the X-ray was able to identify. And it actually quite often changed the Salter-Harris classification of how they were diagnosed on X-ray compared to when they got the CT. So maybe it was a Salter-Harris 3 on X-ray and they got the CT scan and bumped it up to a Salter-Harris 4 or a triplane fracture.
Sure.
That's obviously a much bigger thing to tackle. You know, maybe you see a Salter-Harris 3 and you're like, oh, we'll just kind of put you in a cast. Well, if you would have gotten a CT scan, you see the Salter-Harris 4, the triplane, and you're treating that much differently. So obviously a CT scan is going to give you more information. You can use that to guide your treatment. So when I get a CT scan, the things that I'm looking for are the orientation of the fractures. When I see an X-ray, I can see the fracture, but I can't see the exact plane that the fracture is in. When I get the CT scan to see the orientation of the fracture, I know that I'm planning ahead for where I'm going to put my fixation to be perpendicular to those fractures. And what I'll do is I'll get the CT scan, pop up the CT scan in the OR when I'm doing surgery, and frequently look to it to make sure that my fixation is where it needs to be compared to the CT scan. So I always get a CT scan.
Yeah, always. I think there's I can recall a handful of X-rays that just looked odd on plain radiograph films, and then the CT comes back, and the Salter-Harris 3 fractures clear as day.
Yeah.
Right. And so I think you'd be remiss if you overlook that part of the workup. And again, if you even, I mean, it's a simple test. It takes no time at all. There's really no morbidity in terms of, radiation. I think it's definitely worth in terms of the quality of care once you get that back.
Yeah, I've been fooled before. I mean, I'm not bulletproof, so I make mistakes too. I've been fooled before. I've gotten X-rays before and thought, oh, okay, this is fine. Let me put you in a boot or a cast, and they come back 2 weeks later, and you're like, whoa, where'd that come from? What is that?
Mm-hmm.
And you see some different fracture, like, okay, we're getting a CT scan. So, could you make the argument that, you get a CT scan on every pediatric injury? No, that's not necessarily what I'm saying. Some things are going to fall through the cracks. You're going to miss some things. It's just the nature of what we do and the way that these fractures kind of hide themselves on X-ray, especially if they're non-displaced. But I have missed things before and wish that I'd kind of taken a different X-ray or gotten a CT scan earlier than I did. So I will default to pretty much getting a CT scan on anything that looks, like you said, if it just looks a little bit off, if it looks a little bit suspicious, just go ahead and get that CT scan. So what are the principles of growth plate management? So why do we know why we need to respect the physis. We know the risks of not respecting the physis. So when we go to actually fixate these patients, what are the things that we need to keep in mind? So one of the things that is paramount is placing the implants parallel to the physis. So we don't want to cross the physis if at all possible. So you can see here on that top X-ray, we're going to put fixation parallel to the physis. Whereas typically, if we had that same kind of shear medial malleolar vertical fracture, we're going to potentially be putting 2 cannulated screws across the medial malleolus, but they're going to go from that medial malleolar tip right up into the physeal scar, usually, right, is what we're aiming for with some of our fixation options of the medial malleolus to get good purchase of the screw. Some people go all the way bicortical. I don't, but aim for that physeal scar, and you would be crossing right across the physis in a child. So you're going to have to orient your fracture or orient your hardware much different in a child than you would in an adult. If we do have to cross the physis, called transphyseal, fixation, compression should be avoided. So one of the best ways to avoid compression is to use smooth fixation, K-wires. If we're using a screw, that has the potential for compression. And if you're going to compress across the physis, you have the potential to damage the physis. So if we're using smooth fixation, it's positional, but not compression. We're reducing and keeping it there, but we're not. You can even throw K-wires that are crossing in two planes to prevent pullout, but you're not getting compression across the physis. The last tenet is if there are more than 2 years of growth left of the distal tibia, the transphyseal implant should be removed once the fractures are healed. So that makes a lot of sense. So on the bottom image there, you can see that's a fracture through the physis of a 13-year-old girl. Took her into the OR, put on a distal fibular plate, kept the fixation away from the physis, but spanned the fracture with the plate to reduce it, but not get compression across that fracture. Any
So
thoughts
talking about
on
that
that?
fracture on the bottom right, and for those that are listening, would you call that a Salter-Harris 1 on the distal fibula?
Yeah, I would. And this is a patient who I saw originally with a non-displaced Salter-Harris 1, put her into a cast, brought her back at 2 weeks. So I always see everyone back at 2 weeks with a follow-up x-ray, with the thought process being if there's any amount of displacement, we're going to catch it before the bone starts to heal, which for me in my mind is roughly starting at 3 weeks or so. So I always bring people back at 2 weeks. This was a patient that I treated non-operatively with a cast. She came back. I got this x-ray and I thought, what's going on? What happened here? You're in a cast. You weren't walking on it. I could tell. I looked at the bottom of the cast. She wasn't walking on it and has displacement with gapping laterally at the physis. And so the only thing that I can think of, and this is a good learning point because it hasn't really happened to me before, but it's the only thing I could think of that potentially happened, was that the original x-ray was obtained in the ER and they put her in a boot and then sent her to my office, 1 or 2 days later. And I didn't get new x-rays on that visit. I was looking at the x-rays from the ER. And it could have been that there was displacement of the fracture from the original presentation of the ER to when they came to see me in the office. And that's when the displacement had occurred. So I'm not really sure how that happened, but the end result is lateral gapping of the Salter-Harris 1 distal fibula that I took to the OR and reduced.
Sure. Do you have any thoughts about transphyseal plating versus just stabilization with a positional smooth K-wire? Was there syndesmotic instability in this one?
Yeah, there was. We can go down that whole path of, is there true syndesmotic instability with a low physeal fracture? Conventional wisdom would say no, that's not a fracture pattern that typically results in syndesmotic instability. But when I fixated the fracture, I always stress the ankle, and if there's any increased medial clear space, I'm going to put in a syndesmotic button because I know I'm going to go and take this hardware out anyways. I might as well fix them optimally and then go take out the hardware and know that everything was optimal.
Right.
So I fully understand that this is not a fracture pattern that typically has syndesmotic instability, but I do the same thing for my hundreds and hundreds. Who knows? Someday I'll hit 1,000 ankle fractures and I'll never know it because I'm not counting. But I always stress afterwards, and if there's any increased medial clear space, I will put in a syndesmotic button. So as opposed to, so your original question though was smooth fixation across the physis. So we'll see in a case a little bit later that I did do that. This one, I just didn't like the lateral gapping. And when I stressed it, I didn't put a stress view on there. Her entire talus went with it. So the distal fibula was unstable, right? And the talus tilted into varus when I really stressed it. So I just thought, okay, I'm just going to open this up, put a positional plate on there. But you could probably make an argument for I've done that before. I've put two kind of crossing K-wires in the distal tip of the fibula. And that works okay. This one just felt a little more unstable to me than I was comfortable with leaving K-wires in. So one thing to keep in mind would be the radiographic sign of physeal injuries called Park-Harris lines. These Park-Harris lines are a sign. They can be normal or they can be abnormal. The normal lines are parallel to the physis. You can see here on that image on the left that there is some scarring that is parallel to the physis. That is indicative of a physeal injury at some point, some partial growth plate arrest that then has resumed growth plate function. When you see a Park-Harris line that is perpendicular or not exactly parallel to the physis, that is not a good sign. That is a sign that that area of the physis is undergoing premature physeal closure. And you're going to have to pay real close attention to this patient because the likelihood for complication and deformity is about to go way up.
Mm-hmm.
Any thoughts on the Park-Harris lines?
No, good. I mean, good to notice. I think a lot of individuals will look at pediatric X-rays and see those, and it certainly can be a normal variant as well. But just to get a good appreciation of what's going on there, why there's that line of radio density, just good to recognize.
Yeah. So this is a case of a 13-year-old boy, I think, that I fixed earlier this week with a Salter-Harris 2 distal tibia injury. So trying to describe it for the people listening, it's kind of that triangular shaped posterior distal tibial physeal fracture with a little bit of displacement. On the x-ray, it doesn't look too bad. On the lateral view, you can see maybe 1, maybe 2 millimeters of gapping and displacement, maybe a little bit of physeal incongruity at the anterior aspect of the tibia. But again, there's so much anatomic variability that's difficult to say whether that's real or not. And then you can see here that triangular component of the fracture here with a little bit of step off here at the fibular incisura at the lateral aspect of the distal tibia. So this is one that, according to the conventional research, could undergo closed reduction casting. But what did I do? We've learned it. We're going to get a CT scan. CT scan is going to give you a lot more information. When I get the CT scan, you're a lot more concerned about the amount of displacement at the fracture, especially at that anterior aspect of the distal tibia. There's a lot of gapping there. You can see here that basically what's happened is that fracture has occurred involving the physis, and then basically the distal aspect of the ankle and the entire foot has tilted a little posterior, right? You can see that it's gapping here and here because of some posterior angulation. On the right side of the screen, you can see some gapping there. But the main reason to put this up, and this is a picture of the CT in my OR. So this is what I do. I go side by side. I put these up in my OR, and I have a lateral view and kind of a slice right through the distal tibia, just proximal to the physis, and I can see where I need to orient my screws. Any thoughts on this CT scan?
Yeah, no, I mean, if you look at the X-ray again, the X-ray does look concerning, I think. I mean, it's a large posterior spike. I'd be definitely concerned. I think closed reduction, even on the X-ray, I'd be hesitant. But I think the CT confirms it. I mean, once you see that CT, that's definitely a problem.
So took him to the OR. I put 3 cannulated screws. You can do 1, you can do 2, you can do 3. After I had 2 screws in there, I was not overly enamored with the fixation of the most proximal screw. I think it was just catching a little bit of the fracture. And so those 2 more distal screws had much more solid bite for me. So I just left that more proximal screw anyways. But you can compare the before and the after. So specifically on the lateral view, we're looking at that anterior distal tibia, and it looks much better in terms of the alignment, and you can't even really see the fracture pattern anymore. So with this type of fracture, I'm doing an indirect approach. So indirect means that I'm going from anterior to posterior to tackle a posterior fracture. A direct approach would be going from posterior to anterior for a posterior fracture. The difficulty there is a posterior to anterior approach is better. It is more stable. It's a better construct. You get better purchase into the anterior bone with the posterior fracture. But remember, I'm going to have to go take these screws out. And so the posterior approach is a para Achilles, usually a lateral para Achilles approach, going all the way down, getting through the posterior muscle group, flexor tendons, all the way down to bone, and trying to get those screws back. Putting them in is easy because you can kind of fish your way down there with a K-wire, drill, put the screw in. But getting them back out is going to be much more complicated. So I prefer an indirect approach, which I don't ever have a problem with. So basically, you're going to reduce the fracture. In this case, the reduction was very easy. Basically, by the time he laid on the table with his heel pushing down onto the table, that directed anterior force of this distal component and basically reduced the fracture for me. And I just had to put crossing K-wires across it. So I always make sure that I put at least 2 K-wires in 2 different planes first to maintain reduction, because if you have 1 K-wire holding your reduction and then you drill over that 1 K-wire, you've lost your reduction. So you need 2 points of fixation to maintain your reduction while you drill a cannulated screw. Put in the 2 K-wires, put in the screws with a indirect approach. The alternative option was that I had a large bone clamp available, and I would have made a small posterior lateral incision and then put a reduction clamp from A to P to reduce that before I put my fixation in.
Yeah. How long do you keep the screws in for?
Typically, I aim for 8 to 10 weeks. It really depends on the patient. It depends on how their x-ray is looking. It depends on, are they a little bigger? Sometimes I get some bigger 13-year-olds that are going to be putting a lot more stress on it when they start walking on it. I'm going to leave those in a little bit longer to make sure that the bone is healed. But 8 to 10 weeks typically. This is another article that looks at those Salter-Harris type 2 distal tibia fractures out of the Journal of Orthopedic Surgery and Research. Basically, they looked at ORIF for Salter-Harris type 2, retrospective study, 65 cases in children. Basically, what it said was that they had a residual gap at the fracture of less than 1 millimeter in all their patients, and they healed within 4 to 6 weeks. They did have a premature physeal closure rate of 29%, which is pretty high, I would say.
Yes.
Patients that had a concomitant fibula fracture had a 7 times greater risk of developing the premature physeal closure. And basically, they recommended RF if the displacement was greater than 3 millimeters. So this is what I was saying earlier when the research says 3 millimeters, but I feel really more comfortable with like 1 millimeter of displacement would be okay. But anything beyond that, I'm going to go in and go ahead and fixate. So here's another fracture. This is a more significant fracture compared to the previous one. This is starting to get into a little more complication here. They've got the tibial component and the fibular components. But I did get a CT scan here. This is a significant enough fracture. We're not getting fooled here. We're looking at that x-ray. We're not getting tricked. We're not missing fractures. We can see the orientation of the fractures on the CT scan better and plan our operative intervention, but we're not really gaining all that much knowledge compared to the last case that we saw. But I am going ahead and getting a CT scan here. So when you look at that x-ray on the left, what are your thoughts?
Yeah, I mean, with the tibial fracture there, I'm definitely concerned about the realignment of that physis. I think the premature closure complication rate would be a lot higher on that one. On the fibular one, looking more of a Salter-Harris 2, looks a little bit easier to reduce, a little bit easier to probably achieve some type of stable fixation. But yeah, no, that's a tough injury. What was the mechanism here? Did they was it a sports related injury, or do you remember how this happened?
I don't. I've done 3 recently. One I know was roller skating.
Okay.
I need to listen better when my patients talk. I just see bone. I fix bone. No, I don't remember the mechanism of this one.
No.
I want to say I want to say basketball in the driveway with his friends, but I see so many fractures. Like they get all muddied in
Yeah,
terms of which ones were which. I want to say basketball in the driveway with his friends, but
sure.
pretty significant fracture there.
Yeah.
So this is one that we're looking at the pre and post operative x-rays here. This is one where I used 2 K wires across the tibial medial malleolus. Now, you could make the argument, and I would be inclined to agree with you, that his tibial physis is closed. And you don't need to use smooth fixation across the physis. But why? I'm going to go ahead and take all this metal out of there anyways. If it's going to stabilize the fracture, why risk it? I just went ahead and put 2 K wires across the medial malleolus. Distal fibular plate, you can see where we've avoided the growth plate here with any of our fixation. We've spanned across it. We've brought the fibula back out to length. So here we have some lateral displacement of the fibula with shortening. So bringing that fibula out to length and reducing it back, bringing it back medially, but then not compressing at the distal fibular physis is important here.
How old's the
Looking at
patient?
he was either 13 or 14. I can't remember.
Okay.
Sometimes they change age on me as we go through. You know, they start out 13, and then by the time I'm done seeing them, they're 14. So I think that's the case. I think it was 13, and then most recently was turned 14. So, but anatomic alignment of that ankle here, and then again that syndesmotic button intact there, because there was some widening here at the syndesmosis. So not too different in terms of our treatment compared to an adult, other than making sure that we're respecting the fibular physis and smooth fixation across the tibial physis. What thoughts do you have on any of that stuff?
Yeah, no, it looks good. I think one thing that I think of, and I think we had this conversation, we talked about adult fractures at one point, or adult ankle fractures, is the need for an interfrag screw.
Yeah.
It looks like on that fibular fracture there, we have really just like a neutralization plate to keep it out to length, make sure the anatomy is restored and let the bone heal. So
Yeah.
again, I think kind of similar principles in terms of not needing to put some type of compression across the fracture, but just to neutralize and stabilize it. I
mean,
guess that's where it does sort of behave it in a sense like an adult fracture there.
Yeah, that's how I tackle them. I mean, I think pediatrics on the surface is a little intimidating for some people. But really, when you kind of start thinking about it and breaking it down, it's not all that different. There's a few of those tenets that we went through that you kind of have to respect: the smooth fixation, the fixation parallel to the physis, and if more than 2 years of growth left, remove the hardware.
Right.
Those are kind of tenets to live by, but really we're just reducing fractures. We're putting it back into good alignment. We're keeping it there with some sort of fixation. We're waiting for the bone to heal. And then in this case, we're taking that hardware back out. So really not that different than adult ankle fractures, other than those triplane fractures. When those triplane fractures can present quite a bit of complexity depending on the fracture patterns, depending on the extent of displacement at the fracture site. And so that just takes a little bit more planning, I think. If there's any extent of comminution where there's multiple fractures, that's going to make reduction more difficult. In that first case I showed with that posterior spike distal tibia fracture, the reduction was very simple and fixation was quite simple as well. But if there's multiple fractures with comminution, and this is true in adults also, the reduction could be a lot more difficult. And so when you have the physes involved in muddying the waters in terms of your reduction, I think that's the only thing that can kind of get a little bit hairy is the difference between adults and peds is when you have the comminution that's difficult to reduce, both adults and peds, but the physis is in there. So you can't really sometimes put the fixation exactly where you want it to. Whereas an adult, okay, let's throw 10K wires and put it this way and put a plate over here, put a plate over here. Some of that stuff gets taken off the table with peds. And so, but generally speaking, peds are not that different from adults.
Yeah. Are you thinking about different types of hardware, plates, screws, the size of the screws? Is that ever change for you?
Typically, no, because most of the kids I'm seeing with these type of injuries are um, 13, 14, 15. They're getting to be,
Right, pretty
you
almost
know,
skeletally mature there.
yeah, a miniature version of an adult. They're not far off from an adult versus like a 6-year-old, a 7-year-old. I
Right.
don't see those fractures. I think, most of it is because those kids are bouncy. They're full of cartilage instead of ossified bone. My 6-year-old falls down and if I did that, I'd never walk again, but he bounces back up and doesn't even cry. It's like these kids are kind of flexible and bendable. So, by the nature of what's going on with the bone, I'm typically seeing these kids at 13, 14, 15, and they're a little larger than a 6 or a 7-year-old. So
Sure.
I am typically using very similar fixation to what I'm using in adults.
Yeah. Those are sound principles. I think a lot of great take home points there in terms of um, some of the academics and classification, but really those principles of how to deal with the physis in terms of fixation, not compressing across the physis. So I think those rules are really important for people to recognize.
Yes, I think the takeaways from this from this podcast, I forgot we were on a podcast. The takeaways from this podcast are those research studies that really talk about that high incidence of premature physeal closure, respecting the physis. If there's a significant amount of residual displacement at the fracture, make sure we get that as reduced as possible. Have a short fuse or a low threshold, we'll say, to get in the OR and get those fixed. Classification systems, we've talked about that before on some earlier episodes, and some classification systems being complete and utterly useless, and
Mhm.
some classification systems guiding treatment. In this case, I think it's that what we had described before, which is more of a language for us to describe what the fracture is happening. If I say Salter-Harris type 3, you have a pretty good indication of what that fracture might look like. Now, you don't necessarily know the extent of the displacement or the orientation of the fracture, but at least you can visualize and have some understanding of what I'm talking about. So,
Right.
understanding the Salter-Harris classification in this case, especially for students and residents, is helpful. For attending, it's more kind of documentation purposes. When I have to put in a diagnosis code, yes, I do have to type in what the Salter-Harris type is when I document that. So knowing it and understanding it's helpful, but not necessarily guiding treatment, because there is a lot of variability at the type of fracture. Even between a Salter-Harris 2 could look completely different from a different Salter-Harris type 2.
Yeah. I guess the other point I'd take home is, and I definitely treat way fewer pediatrics than you do, but the kids that I do treat, um, I feel like you're treating the parents as much as the children, and so
Yeah.
it's definitely a different dynamic in terms of
Yeah.
interacting with a child and their parents versus just treating an adult. And so I think having these conversations and really articulating the potential complications, even though fractures can look relatively simple, you can still have some of these premature closure complications. So really just documenting that and making sure that makes it into the medical record preoperatively, I think is really important.
Yeah, I think that's a good point. And that kind of goes back to what I was saying before about how I would want to be treated, or how I would want my own child to be treated. Is you are sitting there in front of the child and the parents.
Mm-hmm.
And so, you know, you have to make a good decision on the front end because of the complications that can occur down the road. If you say, okay, we're going to treat this with a cast, and it's more displaced than you thought because you didn't get a CT scan, and they do get premature physeal closure, you're going to have that conversation with the parents. Hey, why did this happen? Well, this happened, and then this happened, right? So, not that you should, take any patient lightly, but really peds, I'm really careful with anything that we do in any type of surgery, just because they are still growing and changing, and there is so much, there's
Right.
so many issues that can occur downstream that you don't want to be the root cause of.
And maybe these are a little bit easier conversations because we're talking today about non-elective surgical cases, repairing a
Right.
broken bone. But these get even more trickier when you're talking about reconstructing a pediatric flat foot or another type of pediatric deformity that's more of an elective case. That becomes much more difficult.
Right. I agree.
Yeah,
What do you think about my new hat here?
that's nice.
Pod Patrol black and white.
I
That's,
need to get
that's
some swag.
I know. There's a website where you can create merchandise, and I just get on there and I play with stuff, and then I order it, and it
I love
shows
it.
up.
That's
Yeah,
awesome.
my wife's
I need
like,
to
"Did
get a
you
hoodie.
order more stuff?" Yeah, the hoodies are nice. My wife's like, "Did you
Are
order
your
more?"
kids rocking the Pod Patrol at school yet?
Ooh, no, not yet.
Okay.
That would be very confusing because kids are gonna be like, "What is that?" Because they are into Paw Patrol, so it's gonna
Yep.
be super confusing for kids. Be like, "What's happening now?"
That's hilarious.
So we're
Yeah.
gonna, yeah. I like that I have all the merch and then I just wear it. Like
No,
nobody can buy it,
it's
nobody can
working.
have it. You don't even have any of it.
Not
I gotta
yet.
send you some.
Not yet.
I'm gonna get you some. I'm gonna send you some stuff.
We need to send merch to guests also, probably.
Yeah, that's a good idea. We'll
Yeah.
fire that up.
Yep.
We'll work on that. So, all right.
Yep.
Any other thoughts on pediatric ankle fractures? I think that kind of wraps up specifically ankle. I didn't want to dive into like calc fractures and all the other stuff because it's just too much stuff. So I tried to keep it just pediatric ankle fractures for this episode because it's a lot to tackle and a lot to take in.
Yeah, no, I think it's great. And those that are just listening, I would definitely encourage you to check out the video on YouTube. There's a lot of great visualizations. This talk in general is very visual with the CT scans and the X-rays, and looking at the growth plate closure patterns. Sometimes that stuff's hard to follow with just listening. So I would definitely encourage you all to check us out on YouTube and see the video as well.
And while you're there, help us out and subscribe. Little notifications pop up so you can get every single episode. But it helps us out if you subscribe and leave us a comment, and help us out that way so we can grow the podcast, keep pumping out some episodes. We've got a few guests signed up. I think I have 4, 5, 6 people waiting in the wings to come on, and we're going to keep pumping those out for you.
Yeah, it's gonna be a busy summer. Looking forward. I feel like I learned a few little nuggets here each time too. It's nice. Keeps me honest.
I was telling Ashley earlier today, I was like putting some of this stuff together, and it forces me to read literature and come up to date on this and that. And so I'm like, this is, even if 0 people listen, I'm getting better at doing what I do every day and helping my patients. So I was like, you know what? If nobody listens, so be it. I'm getting better at what I do. So I'll take it.
100% agree. I mean, I do a lot of practice boards type questions for students, and in order to write those, I have to research them myself, and it definitely helps you.
Yeah, for sure.
Good to stay current.
All right. Well, we'll leave it off there until next time. Signing off. Another episode of Pod Patrol. Thanks for joining us. This is Dr. Jeff Dikis
and Dr. Leland Jaffe.
We'll see you guys next time.
Take care.